Good evening and welcome to Doctors on Call. What would you like to know about male health concerns like incontinence, prostate, and kidney issues and bladder disease? I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth. Call in those questions locally at 218-788-2844 or toll free at 1-877-307-8762. We have a medical panel ready to answer your questions live. I'm pleased to welcome our panelists, Dr. Travis Moncrief, a urologist with Essentia Health.
Hi. My name is
Dr. Andrew Nisbet, a urologist with St. Luke's Urology Associates, and Dr. John Wood, a family medicine physician at Duluth Family Medicine Clinic. And I would just point out that Dr. Moncrief's picture and Dr. Wood's pictures got crossed, so just make sure you have the names right. Answering our phones tonight, we have our medical students, Blake Holbrook from Cold Springs, Minnesota, Luke Logering from Crookston, Minnesota, and Rakeen Solomon from St. Peter, Minnesota. And now on to tonight's program. And I am going to have each of these gentlemen introduce themselves. So Dr. Moncrief, tell us a little about yourself.
I'm Dr. Travis Moncrief. I work with Essentia Health. I'm a urologist there. My principal interests are in treatment of kidney stone disease, urologic oncology or cancers involving minimally invasive or robotic surgery as well. And I have an interest in treatment of erectile dysfunction, including prosthetics.
Dr. Nisbet?
I'm Andrew Nisbet. I'm a general urologist. I work for St. Luke's Hospital. Ditto. That's all. Those are the highlights.
Dr. Wood.
Dr. John Wood. I'm a program director of the Duluth Family Medicine residency program, which has been in Duluth. It's about the 41st year training family medicine docs for the North Country here in rural Minnesota. And main interest is in educating residents. That's what I do. And I also do some ER work in rural ERs.
And rural America and rural Minnesota very much appreciates it. I think we should start with you this evening. As a family doc, you're a family physician, you're seeing a lot of different male problems one way or the other. What's the most common thing that you see in your clinic that you think we should talk about tonight?
Well, I guess I'd start, we were talking about this beforehand, and I guess I'd probably start with a guy comes into the office with some concerns about maybe screening for prostate cancer. That's often where things start. You know, he's read about something, heard about it, or he might have some prostatic symptoms. Say, I'm going to the bathroom more often, I have to get up at night more often. These kind of things are happening. And one thing leads to another, and there's a concept called shared decision making where we'll have a discussion in the office with this gentleman about the utility of prostate cancer screening. It's changed a lot in my short career, and I'm sure in Ray's career as well. There used to be more of a universal approach with prostate cancer screening, meaning a PSA, you know, you get a digital rectal exam, you do it every couple of years, you jump on every number, and that thinking is still there somewhat, and maybe people my age, but it's certainly changed. So let's say this guy comes in and I do a rectal exam and he's like 56 years old and his PSA is like 6. And I go, what the hey, you know, because that's a little higher than we'd like, and I'd probably call one of you guys at this time and I'd say, because I don't know what to do with that number at that point.
And Dr. Moncrief, you're fresh out. Do you want to take this one first?
Absolutely. So the PSA is not a perfect test, but it's the best test we have at this point. And so a 56-year-old comes in, normal digital rectal exam, elevated PSA. The first thing you want to do is have a long discussion talking about what the utility of the PSA is, what exactly it is, and what it represents. It's not a perfectly sensitive test for prostate cancer. It can be elevated for a whole number of other reasons, including infection, prostatic enlargement, and notably cancer as well. And so you want to have that discussion and then really set the stage for if a biopsy is appropriate, and then what you're going to do with that information when you have it. Because as Dr. Christensen said previously, you kind of treated all prostate cancer almost the same, regardless of how aggressive it appeared. It all needed to come out. Nowadays, there's many more permutations, and there's a different approach. And so there's many patients who have low-risk disease, and you end up not treating them at all, but just surveilling.
Dr. Nisbet, do you want to pick up on that?
I think that's perfect. The decision to screen a man for prostate cancer has to be an individualized one, and it has to be a decision that's made between him and ideally his personal physician, because all prostate cancer is not the same, just as Dr. Moncrief just said. And it's not necessarily appropriate to get a PSA on everybody because, as he said, the number should change what you do. So if the number that the PSA comes back at isn't going to make you do something about it, there's no reason to get it.
So I'm sitting here thinking as a family doc myself, and Dr. Wood and I can probably sit and think about this together. Should we be screening now or shouldn't we be screening? And what should we be doing?
Well,
And this is a tough question.
It is. I don't know what you do, but I personally follow the AUA guidelines. It's the American Urological Association. They have a very nice guideline on early detection of prostate cancer and who benefits the most from getting the initial PSA test and who benefits from basically who benefits from knowing that he has prostate cancer. And they define it pretty well. It's a healthy man between the ages of 55 and 69. Those are the people who get the most benefit.
I would echo that. That's exactly it.
And I think it's also important to remember, I see a lot of patients who have a PSA drawn not just annually, but sometimes every 6 months or something like that. And I think it's important for patients and other practitioners to know that there isn't any data that shows that the annual PSA is any more helpful than a PSA every 2 to 3 years, for example.
Then in the last few years, there's been a tendency to discuss the increase in the PSA and the importance of that. And I just bring it up because from our standpoint, we struggle with how to handle some of those too. So all of a sudden you're running along at a 2 or something like this, and all of a sudden it's 3 or 4, and then where do we go with that? But I think what you're telling me is that between 50 and 65 or 70 years old, you'd probably be more aggressive on those. So the prostate itself then, I'll do this to Dr. Moncrief because I did it to you previously. What's the prostate there for in the first place?
So the prostate is a gland that sits at the base of the bladder, and it's actually where the urethra runs through the prostate, which is where you run into troubles when people are having difficulty voiding. The gland itself adds fluid to the ejaculate during ejaculation, but beyond that, it really has not much else function. And as you age, it mostly ends up just causing problems. So.
Yeah. So then.
So that's why we're here.
That's why we're here. So now that we've got a couple things going, let's talk about the benign prostate first. So if someone's having more and more difficulties passing their water, their urine or micturating, how do you handle that, John, in your office? At what point do you say, okay, it's time for them to see these fellows?
I'd say first it's a conversation we have with the patient, figure out how much there's certain questions you can ask to get a sense of how much they're voiding, how bad their symptoms are, how many times they get up at night. There's a couple of different classes of medications I'd try first, because when the prostate gets bigger, you get increased smooth muscle tone, so the bladder, you get this bladder outlet obstruction, you can't let the stuff out, the urine out, and then you get overflow incontinence, or that you can't void very much, so you're peeing all the time, guys getting up 4 or 5 times at night. And if you get to the point where you try a bunch of different medications and you can't get any relief, then I'd be calling one of you two. And just personal thing, my dad's 95, and he called me the other day and wanted to know if he should have prostate surgery because it's getting up a lot. Sorry, Dad. But I told him that in this case, 95-year-old guy, it's in the wrong hands, that surgery can be pretty risky. So I told him to talk to his urologist and have a good conversation about whether it was worth it. They discussed it and decided to try some other medication to work on that.
Are there any dietary things that can be helpful in treating prostate? It's a question that was called in from here in Duluth. Anything that will lower the risk of prostate cancer?
I'm not I mean, I can say maybe low-fatty diet, you know, in general, you're trying to decrease, you know, free radical stuff, but I can't think of any.
Yeah.
The best evidence is probably, like you said, for having a healthy lifestyle, keeping your weight down, staying active. Beyond that, there are randomized trials out there looking at a number of different supplements, selenium, lycopenes, and none of these have really bore out any strong data to suggest this will prevent prostate cancer.
Okay, let's put that to bed. There's questions coming in on kidney stones tonight, which is good. I've always wondered why a kidney stone has to hurt so bad. Does somebody want to tell me why that is?
Well, kidney stones are painful only when they leave the kidney, because the urine has to flow from the kidney down the ureter into the bladder. And the ureter is this tiny little tube, and it's just designed to transport small boluses of urine from the kidney down to the bladder. It's not designed to hold anything else. So if you have a stone that drops out of the kidney, sits in the ureter, then the flow of urine from the kidney down to the bladder is obstructed. It's the pressure that builds up behind the stone that actually causes the pain. It's not the stone itself.
So how large does it have to be before it won't pass?
So oftentimes, this is a discussion you have to have with patients. Anything over 5 or 6 millimeters, you have to worry that it's going to have difficulty passing. But anything over a centimeter, then I usually say there's almost no chance at all. One good rule of thumb that generally is true, you can take 10 minus the size of the stone, and that'll give you the percent chance. So 10 minus a 5 millimeter stone, about a 50% chance. It's not exactly correct, but it's very close. So at least you can give the patient an idea of how likely they are to pass the stone. So if they come in with a 3 millimeter stone, you can say, you have a high likelihood of passing the stone if you can tolerate the pain associated with doing that and any nausea or vomiting symptoms.
John, how do you treat them initially?
Well, in the ER, it's usually often fairly, I wouldn't say obvious, but you can narrow the differential down pretty quickly to figure out what it is. That's the first thing. Do you do a CT scan? If you have an ultrasound, do you do an ultrasound? Does the person have recurrent stones? That kind of thing. But initially, you give them a medicine probably called Flomax to help dilate their ureter, some pain medications, and something for nausea. There's really not initially a lot you're going to do other than that, a lot of IV fluids. And a lot of these patients, if the stone's small enough, you talk to one of you, you can usually go home and without patient follow-up. The symptoms become worse when you're looking at the patient on the scan, if they've got a big obstructed kidney and you've got a lot of hydronephrosis or an enlarged kidney because that ureter is already plugged up or it's really big, then I'd say, well, I might have to call you guys emergently. At least that's how I'd handle it initially.
Andrew, how long can we sit on them?
I give patients 2 weeks from the time they present with a stone. If they can, like Travis said, if they can tolerate the pain and there's no sign of systemic illness, like a fever or they're dropping their blood pressure or something like that, then with proper pain control, most people can be at home safely passing a stone.
And I think it's important to reiterate the absolute indications for intervention are fevers, where you're worried about a urinary tract infection with an obstructing stone, because that's a life-threatening emergency. You won't clear the infection without having a stent placed, which is like a little plastic tube that drains the kidney. And then also if you have, if you had a solitary kidney, so you just have the one kidney and it's blocked, that's an absolute indication to do something, or else you'll end up on dialysis.
So what do you do? Do you still blast them? Do you use the whatever you call the machine?
Right. Well, the primary goal of some kind of a stone surgery to deal with a obstructing ureteral stone is to unobstruct the kidney, because as I said before, that's where the pain is coming from. So you have to unobstruct the kidney. That involves getting a stent in the ureter. That's a small piece of, it looks like a double pigtail with a small piece of plastic between it. Basically, it goes up next to the stone, allows the urine to drain out of the kidney. If you can do that, then you've unobstructed the kidney and you can address the stone at a later date if you need to. In terms of blasting the stone, if we can get access into the ureter, we have some nifty little tools that we use to go backwards up the ureter. These are small, sometimes digital ureteroscopes, and they have working channels in them that allow for a variety of different instruments to be passed through them.
Wow.
usually under direct vision, we can fragment these stones and pull them out. It's pretty neat surgery
cool.
compared to the way that stone surgery used to be done a couple of decades ago. Even small stones often ended up being treated with large flank incisions, and patients would be hospitalized for a long period of time.
Do you still, at times, have to go in surgically?
There
Can
are
you most of the time get them this way?
Yeah, there are very few indications these days for open stone surgery.
And if you did go in for an open, the question is how would that be done? And what way would you go in? Would you go in posterior or?
So the most common indication that I've seen for going in through a procedure to remove the stone with like a open procedure would be you'd go minimally invasively, usually with laparoscopy or with robotics, and it's usually a renal pelvis stone, and there's like an obstruction at where the pelvis joins the ureter. It's called a UPJ obstruction. And at that site, you would repair that and you could remove the stone at the same time. But most other stones, regardless of size, can be dealt with without having to do an open surgery. There used to be an anentrophic pyelolithotomy, it was called, where you would actually fillet open the entire kidney and remove large, what's called staghorn calculi, which is a stone that takes up the whole kidney, essentially, the entire inside of the kidney. But that surgery, as you can imagine, was associated with a good deal of complications and problems. And so we've kind of moved away from that, and now something called a PCNL, or a percutaneous nephrolithotomy, is where you make a small little track in the back that you can place larger instruments than you could go through the ureter, and you can break up the stone and remove it.
John, are there things that we can do to keep from getting stones?
Yeah.
You know, as family docs, we'd kind of like not to see people get into this trouble if we could do it.
Yeah, because from what we know, or at least what I've read, if you get one stone, 50% of the time you'll probably get another. So you're maybe a stone former, you could think of it as, and there's 3 or 4 different common types. Calcium oxalate, probably the most common. Oxalate is a chemical that's found in, say, rhubarb and chocolate, I believe, and peanuts, and so there's some dietary things you can definitely do for that. Drink a lot of water. Sometimes there's a group of medications called thiazide diuretics that help increase the urine flow, because what you're trying to do is make sure the urine's dilute enough so you don't get the precipitation of these these solutes in the urine. And another thing would be if a uric acid stone would be someone who eats a lot of meat. You might want to say, well, you really need to cut back on your red meat, organ meat consumption. There's certain other kind of stone, styruvate stones that are associated with kidney infections, and there's a certain kind of stone that's associated with a UTI. And so some of those stones you can really prevent. Those first 2, at least, you can try to prevent those. I wouldn't say it's 100%, but you certainly got to do that if you're having a lot of problems with kidney stones.
For one of you guys, floating kidneys, is that something that needs to have surgery? What's a floating kidney?
That's kind of that's not something we would see commonly. I would think of, I don't know, like a drooping lily kind of, or
What do you mean?
Yeah.
Well, the question is,
familiar with the
do you need surgery on a floating kidney that has fallen? And I really don't know what I've never heard of a floating kidney.
I've actually not either.
I think probably if a
I'll get
transplant or something.
I can think of very rare occasions where a kidney is not anchored properly in the retroperitoneum. That's the back posterior portion of our anatomy where the kidney sits, and there are very rare anatomic cases in which that kidney could drop and the ureter would then be kinked because the urine would flow up and then back down again. But
sure.
that's a small case report kind of thing.
Yep. Are cysts on the kidney normal, Travis?
So there's a classification system for cysts, and they start with the most basic cyst, which is just a simple fluid collection, just single cell layer surrounding it. And those are pretty normal. Large population of patients will have those, and there's nothing really to do about them. What you worry about is when cysts get more complicated, meaning they have septations, and then those little septations have thickened areas or calcium.
What's a septation?
Septation is essentially something that breaks the cyst into pieces.
Okay.
So it increases complexity, and that makes you more concerned that it could be some type of cancer, And so then you have to at least follow those, and sometimes they have to be removed.
John, is it possible to get a bladder infection without being sexually active?
Certainly, yeah. Yeah, you can, very common, most common bladder infection in guys is E. coli. It's a gram-negative bacteria that lives in your gut, and you can get pretty sick with that. And so yes, it's very common. Some UTIs, when you're younger than 35, or bladder or prostate infections might be caused by sexually transmitted illness, say chlamydia, gonorrhea. But as we get older, the preponderance is a bacterial infection that's not sexually transmitted. So yes, very common. And very treatable, I might add. So, you know, you can treat that with antibiotics. So.
Is bladder cancer related to prostate cancer?
Generally, no. We don't treat them as related illnesses. They're diagnosed and treated completely differently. Sometimes there will be some overlap between the two, but it's usually true unrelated.
After a prostatectomy, is there anything that you can do to prevent leakage? Travis?
There are. So initially, almost everyone will have some leakage after a prostatectomy. And the thing we teach patients is to do Kegel exercises that will help to strengthen the pelvic floor and helps to prevent that leakage. It's usually a type of leakage where when you cough or sneeze or do something active, you end up leaking urine. And if that fails to work, then there's surgical options as well, one of which is called an artificial urinary sphincter, but essentially you place a cuff around the urethra, and that helps to compress the urethra and allows you to stop leaking urine and having incontinence.
Does the prostatectomy cause sexual dysfunction? Are you able to function sexually after a prostatectomy? And either of you guys, we'll sit back and listen, but what's the story on that these days?
Well, there's a lot of factors that are at play here. When you talk to a man about his risk for post-prostatectomy erectile dysfunction, you have to talk about his pre-prostatectomy erectile function. If it's poor entering surgery, it'll likely be worse after. It depends on the disease itself and whether the surgeon feels that he or she is capable of sparing the nerves that control erectile function at the time of surgery, because we never, as urologists, when we're operating on the prostate for the purposes of cancer, we never deliberately leave behind nerve tissue that we know is going to be compromising the surgical margins and thereby leaving behind prostate cancer just for the expense of preserving a man's erectile function.
We're down talking about the prostate a little bit, and it was a question that ran through my mind earlier, and it did come in by phone call. Are there tests that a man can undergo when he feels like he's not emptying his bladder fully? And
so there's a bladder scanner. It's a little ultrasound machine that most urologists would have in their clinic. So after a patient voids, you'd place the ultrasound machine and you'd check, and it'll tell you how well you're emptying your bladder. And you can have an idea. Because some patients who come in who are voiding frequently and they say, I'm up all night, 5-6 times a night, and all day, seem to be peeing every 30 minutes. If they're only peeing 100 milliliters and leaving the vast majority of the urine behind in the bladder, then that's an obvious cause. And so, and then there's a number of fixes depending on where you think, why you think it's occurring.
John, we get to another age group. What's the recommended interval for testicular self-exams?
When you're below, yearly for sure. You know, and testicular cancer in a young person is devastating and something you want to pick up when it occurs. So a male should get used to examining his testicles on a regular basis, and to make sure that if you feel anything abnormal, any swelling, a lump, anything that feels abnormal at all, pain, you need to be seen right away. And basically, if I saw somebody like that, I would refer right away, like within, pretty immediately, do an ultrasound, or at least get on there that right away, because that's not something you want to sit on, Ray. So.
One of the questions is what causes kidney stones, and I think we've kind of talked about that a little bit before. There's another question that gets into erectile dysfunction, and we're kind of getting low on time. But how does Viagra work? Which one do you want to take that one on?
Viagra is the trade name for sildenafil. which is the class of drug is a phosphodiesterase type 5 inhibitor. It essentially improves blood flow to the cavernosal arteries. Those are the arteries that feed into the corporal bodies that allow the penis to engorge at the time of erection. So it amplifies a man's response to arousal. It doesn't just cause an erection.
And everybody has probably different results. A quick question, but it's not a quick, this is a really difficult question, but what are some of the possible treatments for prostate cancer in the elderly? And you've got about a minute.
In the,
Ready
in the
to go.
elderly? Is that,
Yes.
in the elderly, so the possible treatments are radiation would be a possible
So,
treatment.
and new treatments too, if there are any.
So there's a number of new treatments that are out there, but they're still somewhat experimental. One being you can use ultrasound to high frequency ultrasound to essentially destroy prostate tissue, and that's one treatment. It's called HIFU, and that's one treatment that's been around for a while, but not very long, for treatment of prostate cancer. Radiation is a common treatment. Something called brachytherapy, where you put little radiation seeds in the prostate, is also an option for treatment of prostate cancer. And then surgery, if it's depending on the definition of elderly and how old the patient is and how well they tolerate surgery.
Thank you, guys. This has been a really great discussion. I really appreciate all of you coming in, and it was a nice chance to sit down and chat. I want to thank our panelists, Dr. Travis Moncrief, Dr. Andrew Nisbet, Dr. John Wood, and our medical student volunteers, Blake Holbrook, Luke Logering, and Rakeen Soliman. Please join Dr. Ruth Westra next week for a program on upper GI problems, when our panelists will be Dr. Brad Irwin, Dr. Ken Ripp, and Dr. Teresa Smith. Thank you very much for watching, and good night.